Hi everyone, I'm Stefano Fusco, and I'm going to revise the first case of the Spanish stage. Thanks to Marco and Vid for involving me in this very nice initiative. This is a case from the Hospital IMSCE in Valencia, where I have attended the fellowship last year. So this is a case of a 33 years old weightlifter who suffered from an acute injury, shoulder injury, during lateral shoulder abduction. He had an abduction deficit and a painful passive abduction, and the suspect was of an acute rotator cuff tear. So let's look the MR. This is a coronal intermediate weighted fat saturated sequence. So intermediate because of the TE, it's intermediate between a PD weighted and a T2 weighted image. Let's start from anterior, here the long head of the biceps. Going posteriorly, we see the supraspinatus tendon, which is attached to the humeral head. It's slightly hyperintense, but there are no fluid filled defect within it, so no real tears in the tendon, and the same is for the infraspinatus, while the main issue is more medial, more proximal to the tendon. We see here, and this is the myotendinous junction of the supraspinatus. There is retraction of the fibers, hematoma within the muscle belly, and we very well depict these findings on the sagittal. Let's start from lateral. The tendon attached to the humeral head. While going more medial, we see here the defect at the myotendinous junction, and the edema and the hematoma within the muscle belly with a retracted stump. On the axial, we also can find this hematoma within the fiber gap, edema within the muscle surrounding the intramuscular extension of the tendon, and lowering down we also find this paralabral cyst, probably due to a posterior labral tear, posterior superior labral tear. So the first question was regarding the supraspinatus tendon. The tendon is regularly inserted, as we have seen. There is no full thickness tear of the tendon itself. The tear is more proximal at the myotendinous junction, so there is no delaminating tear and there is no calcific tendinitis. While the subsequent task was to mark the paralabral cyst. We already have seen it, and we asked you if the cyst could be the cause of an acute symptom of the acute symptoms of the patients, and the answer is not. This is an incidental findings, probably due to a radiological case of internal impingement, posterior superior internal impingement. There are also cystic changes at the humeral head, at the insertion of the infraspinatus. He is an athlete who does a lot of overhead weight lifting, so can be due to posterior superior labral tear here, associated with some changes at the humeral head due to internal impingement. And the edema within the muscle belly is not due to denervation, but it's due to the acute trauma. So the answer is an incidental finding. And the next task was to mark the retracted stump. We have already seen it, it's here. These are the retracted fibers from the myotendinous junction here. And we also asked if this tear can be classified according to the Isakos classification, which is the most known arthroscopic classification for rotator cuff tears. The answer is no. This is a non-Isakos tear, since it does not fit the criteria of the Isakos classification, which includes partial and full thickness tear of the rotator cuff tendons here we are at the myotendinous junction, and the Isacos does not consider these injuries. And this kind of injury at the myotendinous junction most typically involve the anterior portion, the anterior bundle of the supraspinatus, and we will see why. It's due to its specific anatomy. And the final diagnosis was the myotendinous junction injury of the supraspinatus, of its anterior bundle with fiber retraction. So why the anterior belly of the supraspinatus, the anterior portion of the supraspinatus, is more involved suffer more frequently from these kind of injuries is due to its typical anatomy. It is a bipinnate muscle with a long intramuscular tendon, and it can generate higher contractile force compared to the posterior belly, which is a unipinnate, more flat and with a broad tendon. So this specific anatomy is well visible on MR, particularly on the axial plane, as seen in this case. This is from a very nice article. I suggest you to read if you don't know this article. It's a very good article. And I want to go back one moment to our case just to show you the intramuscular tendon here in the anterior belly with the edema surrounding the intramuscular tendon at the myotendinous junction. And this is a kind of injury we are used to in the lower limbs, while these injuries are rarer in the rotator cuff in the shoulder, but you have to know that they can occur particularly at the anterior portion of the supraspinatus. Here I've put the Isacos classification just to show you. If you don't know it, I think it's nice to know it since it's very common among orthopedic surgeons, and this classification does not consider, as said, myotendinous junction injuries and the delaminating tears. So these kind of tears are not included in the Isacos classification. So to conclude, we have seen a case of a myotendinous junction injury of the supraspinatus, of its anterior bundle, with a complete tear, with a retraction of the stump, with hematoma filling the gap, and a distal tendon attached. These injuries, as said, are rare in the rotator cuff, but they can occur. You have to know it, and they more frequently involve the anterior bundle of the supraspinatus and the infraspinatus. The risk of these injuries, particularly of high-grade injuries, is that of for progression to a fatty atrophy of the muscle, and for these cases, surgeons tend to do an early arthroscopic repair, but it's not clear if this can really prevent the progression to fatty atrophy. So here some references, and thanks again to Marco and Vid for involving me, and thanks for the attention.